Well, hello, everyone. Thank you for joining today's webinar on engaging communities to improve maternal and child health. I'm Bormit, and I am the Program Director at Christian Connections for International Health, otherwise known as CCIH. We are an international network of 150 Christian organizations. About 50% have headquarters in the US and 50% in other countries. And our mission is to promote health and wholeness from a Christian perspective. And we are glad you are joining us for this webinar on community-based primary health care. Many Christian programs have been pioneers of the principles and practices of community-based primary health care. We're influenced and informed by the World Health Organization and the Alma Ata Conference and Declaration in 1978. Is to highlight community-based primary health care in ways that improve maternal and child health. Introduce each speaker before they share, and we're going to hold all the questions until the end, but please use the chat box in the upper right-hand corner of your screen to ask questions. You do need to be signed into a Google account to comment or to ask a question on a YouTube page. First speaker is Dr. Henry Perry, who is a senior scientist in the Health Systems Program of the Department of International Health at Johns Hopkins Bloomberg School of Public Health. Expanding interest in community health, community empowerment, equity, primary health care, and community-based delivery of evidence-based interventions. And with an MPH and a PhD in sociology and anthropology, CCIH member. Discuss a recent review of 700 projects using community-based primary health care to improve maternal and child health. The book, Engaging Communities for Improving Mothers and Children's Health, of Effectiveness in Resource-Constrained Settings. So I'm going to turn it over to Henry, and I'm going to remind him to please unmute himself so we can hear him. So welcome, Henry.
Mona, thank you. Can you hear me? It's great to be here, and thank you very much for this invitation, Mona. I'm going to be sharing for just a few minutes a project that I've been working on for a decade now and has finally been completed and was published in just June of this year in the Journal of Global Health and has recently been published as a book as well. The journal articles are available online and open access, and so everything that I'll be saying today has backup and much greater detail in these various articles that comprise the series that grew out of our work. Over a decade ago, we were very impressed with the rapidly growing evidence about the effectiveness of community-based approaches in improving maternal and child health. And a small group of us working at the American Public Health Association's International Health Section formed a working group on community-based primary health care. And we set out to pull together the existing evidence about it. This whole working group at the American Public Health Association was inspired by people with a strong Christian background and commitment, including John Wyan, Carl Taylor, Warren and Gretchen Berggren, and Jack Bryant, all of whom are great pioneers in the field of community-based primary health care. Next slide. So we started out, and with the advice of various people, we formed an expert panel of people who are working around the world in community health work, or academics who were involved in this, or in a number of cases, high-level officials in international organizations. And Carl Taylor, who founded our Department of International Health and himself was a medical missionary at the beginning of his career, and a great champion of global health, and particularly primary health care, and particularly within the primary health care arena, community health and community-based primary health care. Unfortunately, Carl died in 2010, and our work was still continuing. And so Dr. Bob Black, who was a member of the expert panel to start with and was the chair of our department for 28 years, took over as the chair of this and led the final work of the expert panel. Going to the next slide. We screened 12,000 articles, and we're looking for any documents that described the effectiveness of a community-based approach, meaning activities that took place outside of a facility, and assess the effect of that intervention or interventions in a geographically defined population. And we looked for evidence of outcomes of several types. One is whether or not there was an improvement in the population coverage of an evidence-based intervention. And so for child health, that included things like immunization coverage or breastfeeding practice or treatment of diarrhea, the application of micronutrients, a very broad range of child survival interventions that we know are effective. And for the maternal health interventions, we were looking for things like utilization of antenatal care, screening of high-risk pregnancies, prevention of postpartum hemorrhage, or prevention of and treatment of malaria during pregnancy, safe delivery. So there were a broad range of interventions that qualified, and we were looking for changes in population coverage of those interventions. We were also looking for assessments of improvements in nutritional status or serious morbidity or decline in mortality. And so this was a major task, identifying these projects. We ended up with 700 assessments in total. 152 had a maternal outcome and 548 had a child or neonatal health outcome. We did not limit our review to peer-reviewed journals, peer-reviewed journal articles, but we included chapters from books. Various books were included. We included 80 USAID-funded child survival projects that had a rigorous evaluation. And a number of these were Christian-related NGOs as well. We found that the majority of the assessments were of projects serving 5,000 or fewer women and children. Many of them had just a single intervention they were assessing, and most of the assessments were for a period of time that was 3 years or less. Next slide. So, as is obvious to everybody who's worked in this field, we know that community-based primary health care is effective in improving maternal, neonatal, and child health. But what's important about our series of publications is that it pulls together all of the known evidence that has been published or is available at this time. And we have, of course, a lot of detail about which kinds of approaches are effective and what the impact really is based on all this evidence. Although it wasn't one of our goals in the beginning, it has become increasingly obvious that the evidence supporting the effectiveness of investing in health facilities without any community-based approaches in improving maternal, neonatal, and child health is defined by changes in health in a geographically defined population is virtually non-existent. And we also looked for, among the 700 documents that were included in our study, we did a separate analysis of the equity effects of those interventions where they were measured, and there weren't a lot of studies where this was done, but we found 42 that assessed the equity impact and the degree to which the more marginalized groups within a defined population and the lower income groups benefited compared to higher income groups. And we found very strong evidence of a pro-equity effect of community-based interventions. And again, looking at the broader picture, there is a lot of evidence that utilization of facilities is highly inequitable because the people who tend to utilize facilities are the better off in terms of education or income status. Next slide. One of the purposes of our review was to look carefully at how these community-based interventions were actually implemented. And we found a lot of evidence of engagement of communities in designing the programs and implementing them and evaluating them. There were lots of examples of assessments and interventions in which women's groups played a very important role. A lot of innovative approaches to sharing education messages, from puppet shows to drama and exciting things that appealed to local people. Virtually all of these interventions and programs use community level workers of some kind, paid or unpaid, a broad variety of people involved in this. There was a lot of use of local resources to support this work, from financial resources to human resources to physical structures. And then a final element in the strategies for implementing these programs involves strengthening of peripheral health facilities in terms of training staff who were based in peripheral health facilities to help them supervise and support the fieldwork in the communities, strengthening the logistic and drug supply systems, strengthening supervision of community level workers, and finally, building links with communities, both for outreach as well as referral. Next slide. Of particular importance were the 4 strategies we identified for delivering interventions, and these involve home visitation, and particularly routine systematic home visitation, where someone is regularly visiting a household, for education, for surveillance, and for building trust and rapport and referrals. So that was an important strategy that was implemented. Community case management was another one, in which a community level worker is trained to recognize serious illness and in many cases actually treat it, as in the case of ICCM, Integrated Community Case Management, where community level workers are trained to diagnose and manage pneumonia, diarrhea, malaria, and in some cases, severe malnutrition. There were other examples of participatory women's groups in which, in one way or another, they were educated and motivated to carry out behaviors that would have benefits for themselves during their pregnancy, their newborns, and their children. And then the final strategy involved the delivery of services at the community level by a mobile team that was based at a peripheral health facility. Each of these were independent of each other and complemented each other. And of course, there were examples in which a program or project used more than one of these 4 strategies. You see here the 42 projects that had an equity effect. And not only were these projects generally equitable in the sense that the lower income group benefited to the same degree as the higher income group, but in fact, they were what we called pro-equitable, in the sense that the lower income groups actually benefited more than the higher income groups. We cited in particular the Brazil Family Health Program and its system of routine visitation of all homes. And in an extensive evaluation that was carried out nationwide in Brazil, they were able to demonstrate that the lower income municipalities where this program was implemented and scaled up had a higher benefit than in the municipalities where the overall income level was higher at the beginning of the program. And as I mentioned earlier, there aren't any examples of pro-equity effects for facility-based care, and lots of evidence of inequitable effects of facility-based care. Next slide. So here's an example of two participatory women's group approaches that were prominent in our review, and there were a number of articles that qualified that were based on these two types of approaches. PLA groups refer to participatory learning and action groups, in which a low-level facilitator comes to a village usually once a month and calls together women from the community, most of whom are pregnant or have a young child, and they talk about what they can do themselves to reduce the risk of a complication or a bad outcome during pregnancy or in the care of their newborn. And this has been subject to randomized controlled trials in a number of settings and is shown to have a powerful effect on reducing both maternal mortality and neonatal mortality. Care groups you see on the right involve a volunteer who works 4 hours a week or so, who is responsible for 10 households. And each volunteer meets with about 10 or so other volunteers as a care group with a paid facilitator who meets with them every 2 weeks usually. And they learn a new message and then related to maternal and child health. And the volunteer shares that message with her 10 households. And then they meet again after 2 weeks, discuss what they did, how it went. They also report vital events. And there are a number of examples in which this approach has had a very powerful influence on expanding under 5 mortality. Next slide. One of the articles in our review looked at the programs that were included in our review in which there was evidence of mortality impact that lasted for 10 years or more. And we found 4 programs that met these criteria in the next slide. These were the Comprehensive Rural Health Project in Jamkhed, India, that Connie Gates will be talking about in more detail. A program in India called SEARCH, Society for Education, Action and Research in Community Health in Gachiroli, led by doctors Abhay and Ronnie Bang, who are now world famous for their research. The Matlab, a Maternal Child Health and Family Planning Project in Bangladesh, and finally the Hospital Albert Schweitzer in Haiti. Next slide. What was interesting to all of us was the common features of these 4 programs. They all involve the provision of comprehensive services, primary health care, broadly speaking, not just strictly maternal, neonatal, or child health interventions, and not just specific interventions, and family planning was an important part of these programs. They all had strong community-based delivery systems with community health workers who are visiting all homes on a regular basis. They all have a strong referral system so that patients who have more complicated problems can obtain care. And there was closely connected to the program a readily available first level hospital care facility that provided, among other things, basic surgical care. They all had a strong management system, a strong supervision of the fieldwork, and strong logistical support for the fieldwork. And they all had developed strong community partnerships and community involvement. Next slide. The overall message from this review is that community-based programming is important for saving the lives of children and their mothers. This slide was built around an article that was first published in The Lancet, but supported our work so closely that we included this in the final article of the series, which is the conclusions and recommendations of the expert panel that was convened for our review. And this slide is a little bit complicated, but what it tells us is that if we were to scale up in the 74 countries around the world where 97% of the deaths of children and their mothers are taking place, if we're able to scale up the known evidence-based interventions to 90% coverage level for community-based interventions, for interventions that can only be provided in the primary healthcare center level, but not at the community, and for interventions that need to be provided in a hospital rather than in the primary healthcare center or in the community. If you were to scale all these interventions up, and based on the known evidence from scientific studies of the mortality impact of these interventions, we would save the following number of lives each year. And so you see here the total adds up to be 2.4 million for community-based interventions, 0.8 million for the primary healthcare center interventions, and 0.9 million for the hospital interventions. And I think this is a very powerful message about why we need to be making stronger investments in the community-based approach, and particularly because the coverage of these interventions is still very low in most countries, except for perhaps immunizations and vitamin A. But the other known interventions still have a very low level of coverage, for which lots of lives can be saved. So the final conclusion of this was we do have a lot of evidence of how these approaches can be effective in improving health of mothers and their young children, but we need more evidence of comprehensive approaches because most of the evidence is based on the effectiveness of implementing one or two or perhaps three interventions together, but we need more evidence of comprehensive approaches at large scale for longer periods of time. I think that's one of the important challenges moving forward. We need more evidence from Africa. Most of the studies, the majority of studies have taken place in South Asia, so there's a great need for more research on these issues in Africa. And we also need to understand why there has been insufficient emphasis given to community-based primary health care, given the strength of the evidence. And there's a very facility-centric approach in the minds of people. Hospital centrism is a very important dynamic, and we need to understand better why people can't comprehend and translate into budgetary significance the importance of community-based approaches. Next slide. So the expert panel strongly recommended that community-based primary health care needs to become a more important part of health programs. It needs to be seen as the foundation of health systems, a priority for health system strengthening, and a priority for health sector funding, which unfortunately is not the case at the present time. And the panel recommended that we begin to look at communities, and especially women in communities, as great assets for strengthening the health of communities, and consider them as valued resources and partners, not just targets, which unfortunately has been the case in too much of health programming in poor countries. Next slide. We need to develop stronger partnerships between communities and the health system and engage communities more in planning, monitoring, and evaluation. And we need to develop a strong integrated community platform so that as new interventions come online that we know are effective, they can be drawn into and integrated into this strong system rather than developing a separate vertical system for specific interventions. And this will be, as I show in the next slide, I think, this will be terribly important for moving through the epidemiological transition. In the next slide, the value of bringing in interventions that address non-communicable diseases. But in order to do this, we're going to need what I call, and many people call, a dual cadre community health platform, in which we have a professionalized community health worker who is full-time and salaried and has 6 to 12 months of formal training, working with a larger number of volunteers who have a smaller number of households of 10 to 15 or so. Community health workers serving 1,000 to 1,500 people. But we also need to continue research in this area to continue to strengthen programs and to learn how to better provide these services at scale, which is a different order of magnitude than running a small research project. Next slide. The expert panel considers that stronger community-based primary health care is essential for achieving universal health coverage and for ending preventable child and maternal deaths by the year 2030, which is global health goals now for UNICEF and WHO and virtually all the countries around the world. And the vision of community-based primary health care that was outlined in the 1978 Declaration of Alma Ata is more relevant than ever in terms of getting services close to where people live and engaging them as partners in the process. So as I mentioned a minute ago, this platform will be effective and important not only for mothers, neonates, and children, but also for family planning for women, for prevention, screening, and basic treatment and referral for HIV, malaria, tuberculosis, and looking to the future, but the very near future in many countries, giving increasing attention to hypertension, diabetes, mental illness, and the health problems of the elderly and very low income settings. Carl Taylor, our great hero in global health, in the last article he published just shortly before his death, made this statement that we like to use as a focal point for our thinking in this area. Real social change occurs when officials and people with relevant knowledge and resources come together with communities in joint action around mutual priorities. The time has come for community-based primary health care and community health workers to no longer be an underfunded afterthought and to move to the center stage. As I said in the beginning, these articles can all be downloaded, and here's the link you can see. And then we also have a book that's available in the next slide that can be purchased on Amazon.com. If any of you listening would like to have a copy of this book, I do have a small number of these that are available for people who are interested that I can distribute for free. Next slide. And here you'll see all of the specific articles with their detailed titles and the full authorship for these. This was an effort that involved more than 150 people of one kind or another. There was a lot of work that went into abstracting the data from these documents and putting them into a database. And so we could never have achieved this without a large team of people. So thank you very much for the chance to share this with you today. And I look forward to answering any questions that you might have after Connie speaks.
Thank you very much, Henry, for sharing. A lot of food for thought. I'm just going to remind you to please mute your microphone.
Okay, I sure will.
And we'll have questions for Henry at the end. So please remember to put any questions in the chat box in the upper right-hand corner of the screen. And you do need to have a Google account in order to be able to ask a question. And I'd like to introduce our second speaker, Connie Gates, who is a founding member of CCIH. Connie has volunteered at CRHP JomCAD part-time and currently is its international training coordinator. In the 1970s, Connie was introduced to Dr. Rajaroli and the Comprehensive Rural Health Project in JomCAD, India, a pioneer of community-based primary health care. Program's contribution to the field of community-based primary health care, as CRHP was one of only 4 projects and the only Christian-based organization identified in a review that had evidence of mortality impact for at least 10 years, part of a seminal document leading to the 1978 International Conference on Primary Healthcare and Alma Ata Declaration. So Connie, I'll turn it over to you. I'll remind you to please unmute yourself so we can hear you. Connie.
Hi. So hello, CCIH friends. Sorry I can't see you, but I think you'll be able to see me after the presentation. So first, I would like to talk about the Christian contribution to the development of the Alma Ata Declaration that Henry just referred to, Declaration of WHO and UNICEF. So this is my version of the story. First, what is the Alma Ata Declaration? It was the document as the culmination of the International Health Conference held by WHO and UNICEF in Alma Ata in 1978, which put primary health care, PHC, on the global health agenda. And those of you old enough might remember the motto, Health for All by the year 2000. The declaration was signed by 134 countries, including the US. So how did WHO learn about PHC? Mainly from the Christian Medical Commission, CMC, of the World Council of Churches. Its office happens to be only 2 blocks from WHO in Geneva. This history is also documented in the article by the WHO historian Socrates Litzios, and there's a link on the CCIH website if you want to read more about it. CMC started in 1968. One of its main goals was to help church mission agencies rethink medical missions, and PHC was one of its priority concerns. CMC learned about PHC from Christian programs throughout the world who were innovating new ways of working with communities to improve health. CMC had an advisory committee chaired by John Bryant, and Carl Taylor was also a member. So these names you'll heard from Henry and you'll hear again from me. The committee met annually for about a week, during which time a few of these international pioneers were invited to share their experiences, and then other relevant issues were discussed. So in 1972, Dr. Roger Rowley from CRHP, Comprehensive Rural Health Project in Jomked, presented, and that's when I first met him and learned about CRHP. One way that CMC shared their ideas was through the publication of Contact, a magazine called Contact. Through this vehicle, some editions were about these projects and other editions were more focused on issues of interest. I worked at CMC in the early 1970s and had the privilege to produce the first 15 issues. And Contact number 10 happened to be on CRHP Jomked. In 1975, WHO published a book called Health by the People, with chapters on various innovative experiences throughout the world. National programs, and there were 3 community programs included in the book, all of them Christian, and one of which was CRHP. Then in 1978 was the conference. Carl Taylor was the drafter of the declaration, and John Bryant was a member of the US government delegation. He was working in the International Health Office of DHHS then. There was great excitement among people who believed in PHC and its possibilities. Unfortunately, the promise of the Alma Ata Declaration was soon undermined, but that's another story for another time. The 10-year anniversaries of Alma Ata have been motivating times to revive the interest in the conference and declaration, its history, and what has happened since. WHO has had some of these anniversary meetings, and other groups also, such as CCIH 2008 conference, when Carl Taylor and Jack Bryant shared their experience. And a document from that presentation is also on a link on the CCIH website. Here is the 40th anniversary. So there are folks, again, engaged in some renewed efforts, including CCIH. There are many people, including Christian organizations and individuals, who have continued to be committed to the principles of Alma Ata. In this approach of improving the well-being of people, especially poor and marginalized. Thus, Alma Ata is still alive and relevant. And that brings me now to talk about CRHP, which embodies Alma Ata principles and exemplifies Alma Ata in action. Many people after Alma Ata thought it was too ideal, but CRHP shows that it can be real. So the Comprehensive Rural Health Project, CRHP, in Jomked, India, was started by Dr. Raj and Maybelle Aroli. So here you see a map of basically where it's located. They were Christian doctors who met during medical school at the Vellore Christian Medical College in India. They fell in love, especially when they found they shared a similar vision and mission of serving the rural poor of India. In the early 1960s, they worked in a Christian mission hospital doing good medical care, curing many people, delivering babies, etc. and also going to villages to provide clinical care. But after a couple of years, they realized they were having little impact on the health of the majority of the population, especially the most vulnerable. And also they were treating communicable diseases and sending the patients back to the same place where they contracted the disease. They thought there must be a better way, a way that was more consistent with their Christian values and mission. But in those years, in the 1960s, the global push was to get the Western medical model throughout the world, through Christian missions as well as NGOs and governments. So they went to the US for additional training, including Masters of Public Health at Hopkins, and that's where they met Carl Taylor. And then they returned to India and ended up in Jamkhed. I don't have time to tell you much about CRHP, but I wanted to share a few key lessons I have learned since I was first introduced to them in 1972, and now having been working with them for 20 years. So CRHP is a health system, and this is how a diagram that they use to show their health system. So on the left side is the community level, with village health workers as the key change agent and community groups addressing various aspects of their lives. In the middle is the mobile health team, which is a bridge between the community and the health center. And on the right is the health center with secondary care hospital, a training center, and administration. So the village health workers, CRHP was one of the first programs to use community health workers, especially illiterate women, into schools in those early days. CRHP's approach is to facilitate the selection of a VHW by the villagers, who is then accountable to the villagers. And usually there's the village average size is 1,000, and there's one village health worker for that size population. She is trained and supported by CRHP staff, mainly the mobile health team. She works as a volunteer, and her main role is to share what she learns with others in the community. Workers don't need a health career path, but they choose what they want to do to earn income for financial independence. The enrollees were amazed at how eager and how able these women were to learn and to share. Oops. The success of the village health workers is especially based on the support of community groups. The mobile health team facilitates the organization of these groups. They are initially composed of socially minded people who are organized around their self-interest. These groups provide a forum for learning and problem solving and mobilization for action. Empowerment of individuals and communities is a basic principle of this approach. This was the goal from the beginning of the project in order to develop a sustainable process that improves the well-being of all people, especially the poor and marginalized women and children. At the beginning, the CRHP staff spend a lot of time developing a trusting relationship with the community. With this foundation, the partnership is strong and much is accomplished rather quickly, especially by the villagers. They use a process they call AAA cycle. The first day is the assessment of problems and local resources and set priorities. Second is the analysis of the causes or determinants of the problem. And then they come up with an action mainly using local resources and government programs. They use participatory rural appraisal tools a lot in order to have the community be actively involved in this AAA cycle. Initially, the mobile health team facilitates this process, but over time, the community groups take on more responsibility. They address the root causes, social determinants, including other development sectors, integrate marginalized people into the community, raise the status of women, overcome the caste system, social and behavior change, especially harmful traditional beliefs and practices. This process becomes sustainable, building the capacity of communities to do for themselves. And I like to use the phrase communities health themselves. Over the past 50 years, they've worked in over 250 villages in their area. And so that's over a population of over 250,000 population. And now most of these villages are self-reliant, so they're not actively engaged in those villages. So this is often referred to as the JOMKED model. So these are just some of the basic elements of or characteristics of the JOMKED model. It's comprehensive, it's community-based according to the empowerment process. It is primary health care according to the Alma Ata Declaration of Primary Health Care. It's health development, two sides of the same coin. It's values-based, it's not just a technical, and it's a process, it's not a project or program, and thus it's sustainable. So related to the study that Henry has described, CRHP's impact for more than 10 years, he identified 4 programs, but now CRHP is almost 50 years. But this slide shows especially the MCH indicators of CRHP. So you can see in the first 5 years the great impact they had. The red line is the infant mortality rate. And then you also want to look at malnutrition that starts at 40 and goes down to almost nothing. You see that the antenatal care and safe deliveries and family planning start at almost nothing and go up to 80 and 90 and 100%. And this data is only until 2006, but you can see from 76 to 2006 that it continues to be good, and that's because of the empowerment of the communities. They're the ones that are doing this, and the statistics continue. But you can see that, especially in terms of MCH, they've been able to address those issues and continue to do so. So the communities have also been able to bring communicable diseases under control, and now they're more focused on NCDs and mental health. So I like this, also this quote about the impact of this program, of this process. The impact of the project can be assessed by the statistics which show the results achieved over time. Beyond these numbers are self-confident men and women, once outside the mainstream of society, taking leadership positions in their villages, affirming that they are created in the image of God. It is not only the quantitative changes that are important, but even more so the transformation of persons and communities in a qualitative way, which leads to harmony, health, and peace, or shalom. And as I mentioned earlier, that this is a sustainable approach or process. So this is the characteristics of the sustainability. So first is knowledge and skills. So building the capacity of communities to do things for themselves. But they also need to have the attitudes and values. I said it's more than a technical approach. So really building a caring community and having a lot of volunteers, the village health workers, the community groups, people working in the community for themselves. And they continue to be motivated. The village health workers are still involved after decades, and they are training newer ones. With prevention, early detection, treatment, and rehabilitation in and by the community as much as possible. Emphasis on holistic health, determinants of health, the multi-sectoral approach, using appropriate technology and local resources, spread by villagers to other areas, and the process that I described earlier of working with communities, and the JOMKED model approach as a health system. So its current mission is really to share its experience with the world. And these are just some examples of how it's had an impact on various levels in the world, as well as how they're sharing with it. So the expansion, as I said, it's been spread to over 250 villages in the JOMKED area, and that was mainly spread by villagers to other villages because they are the best ones for teaching. They also, for scaling up, they're really doing training partners. So there was an organization in Andhra Pradesh, the state next to ours, with a 60 million rural population, and they sent thousands of people to JOMKED for training. And then with the United Methodist Church, they sent people from all over Latin America to also learn and to apply. So this also shows that it's applicable in different contexts. So learning from CRHP, they've established the John Kidd International Institute for Training and Research, and they also have a mobile training unit. And students from various disciplines come, FBOs, NGOs, government, and everyone from grassroots to policymakers. It doesn't matter what educational level or what work they do. So far, over 30,000 Indians and over 3,000 internationals have come. Then also they do networking at the state, national, and international levels to share their experience, publications, articles, papers, books, chapters, presentations. And then they've had impact on policy at the state, national, and international levels. They've been members of various committees, and they've also done advocacy work. So in conclusion, I would just like to share this quote from CRHP. Ours is not an innovation in technology, but rather an innovation of the people within each community to bring about social change and thereby uplift everyone from poverty and disease. Emphasize belief in a loving God, the spiritual aspects of health and Christian values in our training and our work. Transforming lives, building the kingdom of heaven on earth. Thank you.
Thanks, Connie, and thanks, Henry. Questions come in, and so I'm going to start with a question for Henry to give Connie a break. So, Henry, one of the questions that was asked are, what are the reasons many governments prefer to invest in hospitals, community-based approaches?
That's a great question, and I think Ray Martin provided that question. Thank you, Ray. Well, it's a complicated question, but a very important one. I would say that there are multiple reasons. The first is the power in the minds of people of curative care provided at facilities. And even if you go into villages and ask them what their health problems are and how they could be improved, they say, we want a hospital, we want a doctor, we want an ambulance. So the belief in curative medicine is very powerful, but people don't fully appreciate the power of basic hygiene, nutrition, cleanliness, and very simple things. And we've been mesmerized by technology and curative care, and that's an interesting question as to why that is. But when you look at the national level, there's an enormous political pressure to invest more in facilities, whether they're hospitals or whether they're primary healthcare centers. And that comes from two main sources, in my view. One of them is that the political elites in most countries and also the leaders in Ministry of Health, they represent a curative orientation that supports the idea of investing more in hospitals, and particularly tertiary care hospitals, which absorb enormous amounts of money. There's a prestige factor there. There's a political factor there that leads governments to do that. But the second is the people themselves who work in facilities have a powerful voice in the distribution of resources to support health systems. They can go on strike, nurses go on strike, doctors go on strike for better salaries, for example. And so when you add all that pressure up, there's not a offsetting similar pressure to support stronger community health programs, even though the evidence is there that they can save more lives. And so part of the challenge is to try to figure out how to address this problem in a way that really has policy impact. And the country of Ethiopia, where I'm now working, has really overcome these issues and has, with very strong political leadership, shown the importance of community-based programming. And one of the great bright spots on the horizon now is the election of Dr. Tedros as Director General of the World Health Organization. And his election was fueled primarily by the success that he provided leadership for in Ethiopia to build this system up. And so I think there's hope but the concept of hospital centrism and its capacity to suck in resources to the detriment of primary health care at the community level is a very powerful issue we need to be thinking and talking more about.
Thanks, Henry. I appreciate it. I'm going to switch to Connie to give you a break. So Connie, remember to unmute your microphone. One of the questions is from Paul at SIM. When the community is self-reliant, sin and self-centeredness is pretty rampant. So where does the sustainability come from? Yeah, there you go.
I am unmuted. Through this process, especially those initial years of working with the village health worker, the community groups, they developed this culture within the community that breaks down all of the overcomes these social barriers of the women's status and the caste system and things like that. So they just, I think, build on their successes when they see that they can do things for themselves, that the communities can do things for the communities themselves, that continues to motivate them. And as new priorities, as they identify new priorities, as they identify new problems, they know that they can do something for themselves. And I don't know, it's magic, yes, but it happens. It happens.
Okay, thank you, Connie. I'll switch back to Henry. Henry, one of the questions is, did you find evidence of ways to keep a real balance between the hospital/clinical-based approaches and the community-based ones? Have Christians found innovative ways to do so?
Right, that's another great question. That was not actually one of the objects of our study, but I guess it's still a legitimate question anyway. How to create an effective, well-functioning hospital that doesn't require extensive resources to operate is one of the great challenges of global health, in my view. We need more evidence about what it takes to have an effective hospital and how we would define an effective hospital and what is the level of minimal technology and staffing and so forth that's required to be able to provide those services is a great issue. And how we can make surgical services available with people with limited training is another important question. So when I was the director of the Hospital Albert Schweitzer in Haiti, which is one of the 4 programs that had longer term impact, even in that setting where there was a deep commitment to community-based primary health care, about 2/3 of the budget of the organization went to support the hospital. And even for me as the director, I didn't have a lot of capacity to shift that for a lot of different reasons, one of which is related to what I said just a minute ago. To do that would have required laying off a lot of people if you were to make a major shift in that budget, and those are very difficult things to do in settings where employment is very scarce. Thinking about the Jomcat Hospital and the hospital at Search, in both of those cases, I think there's a better balance between the resources that go into the hospital compared to the resources that go into the community. And in those 2 cases, the people who set up those programs had a very deep commitment to community-based programming. And in the case of the Hospital Albert Schweitzer, Dr. Larry Mellon, who started that program, I don't think was ever completely convinced of the power of community-based approaches. And Gretchen Berggren, who is on our call here, I don't know whether she can speak or not, but they were privileged to start the community health work at the Hospital Albert Schweitzer, but Larry Mellon, them to raise the money for their work and didn't really plow substantial resources into it like he was investing in the hospital. So the leadership of the program matters so much in the relative resources that go into a hospital component versus the community component.
Okay, thank you, Henry. I'll switch back over to Connie. So Connie, one of the questions is, given the spectacular success of CRHP, one would hope that other regions in India would adopt similar approaches. Has that happened? Why or why not?
Yes, it has happened. One example I gave quickly at the end, because I was running out of time, was the program that in Andhra Pradesh, so 60 million people in rural Andhra Pradesh. There was a pilot project started in each district. People came to Jamkhed for training, and then the mobile training unit from Jamkhed went and visited them. And that continues. Even the state was divided, so there was a little delay there in trying to continue it. But that's a good example. Also, Maharashtra is sending people. Bihar is also been sending people. In terms of more of a statewide basis, a national-wide basis, Dr. Rajaroli was the NGO representative on the Prime Minister's Commission to develop the National Rural Health Mission 10 or 12 years ago. And so he was very involved in that. And some of the ideas that were developed in the National Rural Health Mission were lessons that were learned from Jamkhed. So, and that's why I was saying at the end, the impact that Jamkhed has had at the state, national, and global level is really impressive.
Great. Thanks, Connie. So I know we could ask many more questions, but our time is coming to a close. So I just want to give each of you questions or anything else you'd like to add. Henry, I'll start with you.
Well, for me, as somebody who spent my career focused on the work that Warren and Gretchen Berggren did and their mentor, John Wyan, and having been closely associated with Carl Taylor, and seeing the resistance to the development of community-based approaches as we've dealt with so many obstacles related to overinvestment in hospitals and the enormous investment in very highly selective top-down approaches. It's very gratifying to me to see the growing evidence of effectiveness in this area. And policy, in fact, is driven by evidence, but there's usually a lag time of 5, 10, or perhaps even 15 years. And so now that I'm 70 years old and moving into semi-retirement, I take a lot of pride in having played a very small role in trying to bring some of this important evidence to the table, and to have it in a form that's readily available to policymakers and decision makers and technical experts. And so I think the early pioneers, many of whom came from a Christian background, their work has been instrumental in getting us to where we are. And I'm excited about the future and looking forward to this day. I hope I'll still be alive when we've ended preventable child and maternal deaths and made universal health care available to everybody. And I don't see how we can do that without strong community-based programs.
Connie? Any comments?
I would just like to encourage people to learn more about community-based primary health care if you're not already convinced or engaged in it, and to think of next year as the 40th anniversary of Alma Ata, to use that as a time to re-engage in the belief that community-based primary health care is the way to go. And you're all invited to Jamkhed. Be in touch with me, and I'd love to have a CCIH sponsored group come to Jamkhed.
Wow. Wouldn't that be fun, Connie?
Yeah.
Well, I'd like to thank everyone for joining us for today's webinar on community-based primary health care. available on CCIH's YouTube page, and we encourage you to share the recording with colleagues who were unable to join. I hope that you share your lessons in community-based primary health care that's being done in your organizations, in your networks, in your communities via one of CCIH's networking groups. And I'll put the link in the YouTube page so you all can see it. And I just really want to thank Henry and Connie for taking their time and their lessons to share with us. Everyone is having a blessed Advent season and has a very Merry Christmas. So thank you for joining us, and bye.